Welcome to The Cut, a series where I'm talking to experts about how small changes can have a big impact on patient outcomes after surgery. Hi Ridian,
Hi,
how are
Kylie.
you?
I'm very well, thank you. It seems like we've been talking for a while now.
It does, doesn't it? But we could talk forever and a day about incision care, can't we?
Yeah, listen, there's so much to be discussed, so much still to learn, and you and I are both advocates of good
Yeah.
practice, and we're both keen to spread the word.
Yeah, I agree entirely. And one of the ways we do this is through ICECAP, or the International Surgical Wound Complications Advisory Panel. Take a breath after that. It's quite a long word.
is,
Or
but
ICECAP.
But it does what it says, and thank you ever so much for inviting me onto the panel.
Pleasure.
Because I've learned so much from everybody, and the fact
We've learned so much from you as well.
Bless you. But the working in a multidisciplinary team, not just surgeons, because most of the work is I'm always with other surgeons, scientists, physiotherapists, vascular surgeons, wound healing experts. That's a godsend for me, because I'm in a room with like-minded people, but I'm constantly learning, because I'm aware that as a surgeon I can be a little bit two-dimensional at times, and challenging myself by working with really good people from other disciplines. That's a great chance I've had. Thank you.
Oh, pleasure. It's a joy having you, because you bring that different perspective. Everyone brings a different perspective at ICECAP. I learn as well too. Scientists can somewhat be myopic sometimes, so can surgeons. But I think we all complement each other really well. And one of the things that we have done recently, of course, is our consensus document, looking at prevention, detection, early diagnosis. One of the things that struck me in the document was around prevention. And I know you're working in that space.
Yeah.
So tell me a little bit about the story for you.
Well, I've spent 20 years treating the effects of infections, wound breakdown around knee replacements and trauma. And trust me, you'd much rather avoid the complication than treat it. And as good as we are, we can't cure everybody. And to get a cure, they go through pretty invasive surgery. And there's a friend of mine in London says that even our winners are losers. So when you're treating an infected joint, however good the outcome, it's not as good as it should have been. When they have their first time hip or knee replacement, that should be a life-changing intervention. But you get a wound breakdown, you get an infection, have multiple operations, and suddenly, even in the best hands and the best outcomes, it's second rate, even if you get the infection. So prevention, has to be the way forwards. And with that in mind, we've talked earlier about optimization, we talk about risk stratification, and that is so important because it's not that difficult. You can pick the high-risk patients before they come to theatre. And we should be thinking not just as surgeons, not just about what operation we're going to perform, but how am I going to close that wound? What dressing am I going to use? What's my post-op protocol? How can I minimize complications? And we should, again, from the first time we meet the patient, start to risk assess them and say, look, what comorbidities do you have that we can prevent? What problems might likely arise in your leg because of obesity, because of circulatory problems, because of long-term immune suppression? There are previous surgery, previous trauma. I see a lot of patients with scars everywhere. So you can pick the complex cases as they walk in the door. And then to say, look, I'm going to do this complex patient, I'm going to do a big operation, but you know what, the dressing doesn't matter. Anything will do. You guys choose. That's wrong. It has to be. You have to stratify the risk and choose well. That's how you prevent complications. And you won't prevent all of them, but you should be thinking, how do I minimize complications so that patients benefit?
That's true, because it's a multifactorial issue, but it's also a segmented journey. So you've got the patient prior to surgery, what's happening in theatre, and then you've got that post-operative recovery period, which is all under the jurisdiction and the care, the stewardship of the surgeon.
Absolutely, and it should be. That's a great word, the journey. We do compartmentalize too much. Because I'm a surgeon, it's the theatre time, it's the operation.
Everything that's happening in theatre.
Absolutely, it's all about me.
Yeah.
And you're working with the patient, not on the patient. You're with the patient, and they're the ones that goes on the journey. And so we have to prevent early on, but then choose wisely afterwards. And surgeons, I feel, don't really engage in this enough. Both ends, the optimization beforehand, the good dressing selection afterwards. And it genuinely frustrates me when I'm sent complex infected wounds that frankly could have been treated, prevented ahead of time. Just a little bit of thought, just stepping back a little bit, assessing the patient, assessing the risk factors, choosing the right operation at the right time, and then the right post-op protocols, the right dressing management. And it doesn't have to be the same dressing for everybody. Equally, not every patient needs a negative pressure incisional dressing. But the options are there, and we should stratify the risk to choose wisely. That's how you minimize risk and get prevention.
Absolutely, and I think the other thing too that I've noticed in the field is around prediction sides. So predicting those at risk. It's a little bit of guesswork. There's not many tools out there to assess, but I've recently published one, but that's one. We need more.
We do, and I've done some work with Brian Andrews and Mullica looking at risk stratification, and through that we ended up having a very productive day at the Coxa Hospital in Finland, and they've got a phenomenal database, I think 50 or 60,000 patients now, and they can put in 3 or 4 simple demographics and give you both an individual risk and a relative risk profile before you operate. And then show the patient if your BMI comes down to this point, if you stop smoking, if you correct your anemia, then your risk changes significantly. And, again, it's not rocket science, but it is, isn't it? It's
and that's
data.
Where the data backs up the anecdotal experience.
Yes.
But do you think without that, we're rolling the dice?
So you then back to good surgical judgment, aren't you?
Yes.
Yeah, and that becomes very artistic rather than scientific. And we get it right most of the time. It's getting away with it. Is that good enough? I don't think it is. What we need though in this day and age is a little app on your phone or your tablet, so you can put in those demographics in the clinic. And so you can actually show the patients, give them feedback immediately about, this is the operation you need, but actually your risk is too high at the moment. Let's change these factors. You need to go on the journey with us as a patient. But when those factors are back within a safer zone, we'll do the operation. The question is if patients don't change behavior, and we've talked about surgeons changing behavior, about dressings, patients also need to understand their lifestyle choices have an impact on risk after surgery.
Yeah, their outcomes, essentially.
Absolutely, yeah.
So you can do the greatest, best surgery in the world, have this whiz-bang, fantastic dressing, but unless you stop smoking or lose a little bit of weight, it's all part of the jigsaw puzzle, isn't it?
Yeah, completely. And the best dressing in the world will give you that marginal gain at the end. But if you have a summation of marginal gains, you get improvements. And I find it amazing that if you've got something that is clearly an improvement on historical paper dressings we used to use, why wouldn't you use it? Why wouldn't you give that patient the benefit of what's out there now?
Yeah. Rydian, always a pleasure.
Thank you.
Thanks for sharing the story today on The Cut.
Thank you.